is Dr. Holli Temple. She is from the University of Texas at Austin, so she's a home girly right here. But she started out as a pharmacy technician, just like the rest of us. She worked her way through not only the trenches of the retail setting at Walmart pharmacy, she has not only her PharmD from the University of Texas, she also has a, I'm going to let you say it, biomedical science degree from Texas A&M. Yes, Texas A&M.
House divided.
Practiced hospital pharmacy for the last 16 years, and she joined UT Austin College of Pharmacy in 2011 as a member of the faculty. Her enthusiasm for institutional practice and medication safety into the basic intravenous admixtures course. So these calculations are right up her alley. She also teaches the Foundations of Patient-Centered Care course and coordinates the Care and Respect for Elders program.
And so I said, well, I teach the sterile compounding to students, and there's a small subset of students that really, really struggle with calculations. And so we'll go into some of that, maybe those reasonings as we go through today. And then I also made a couple of very serious calculation errors when I was a practicing hospital pharmacist. And I'm like, oh, if I can, slow down, double checks. Technician's like, hey, this doesn't seem quite right. This is a lot of dextrose, and this is more than I usually put in a TPN, one of those total parenteral nutrition solutions that contains fats, amino acids, dextrose, and a bunch of electrolytes. But she was like, there's 2 competent pharmacists that are checking, so she didn't speak up. She was the one that got the dose right. But anyways, long story short, I was just emphasizing, we need you guys and you need us. Anyways, it makes a great team. So I want to encourage you, just kind of starting out, if that little, something's not quite right, you may not be able to identify what's wrong, but you know that something's not quite right, bring it. Bring it to a peer, bring it up to the pharmacist, say, hey, something's not right, can we just double check this? And if that pharmacist won't listen, bring it to someone else. Because at the end of the day, it's what we send up to the patients, what we dispense to the patients, that needs to be as correct as we can. We are human, and we tell the pharmacy students, we do make mistakes. We hope they get caught, but they don't always get caught. But how can we kind of recognize those potential errors is by education, practice, and then when things come up, share, right? Oh my gosh, I miscalculated this heparin dose. Well, what happened? How did that happen? And then teaching other people how to calculate that, and then revisiting it. Because if you sweep it under the rug, somebody else may make that same error. So that's kind of my rationale, I guess, for providing this topic today. And my clicker is here. Okay. So as we work through things, we're going to discuss some common drug calculations, and I have some examples in the community and hospital settings. We're going to look at some examples and kind of where and why these errors occur. We'll discuss some strategies to help us catch those errors. Unfortunately, I do not have any financial relationships to disclose. One day, maybe. And then I found this: good intentions are no excuse for incompetence or poor results. Nobody comes to work and says, I'm going to make a calculation error today. We want to do the best we can, but things happen, right? We get busy, we get distracted, things happen. But I would like to say that you guys are all very competent, because you wouldn't be here if you're not. But we just, so good, just being, hey, I'm going to do the best I can, that's not enough to actually have something that's accurate being delivered to the patient. We're going to go through 3 different calculation scenarios today, and then we'll kind of do some practical examples after that. All right. So first scenario, and then you have and if there's not one right next to you, I tried to put, for those that are in person, I tried to put a little, if I could see where you were sitting, so you have a little handout. So those are the calculations. So if you kind of want to work through those as we're going through, that's fine. If you're like, I'm good, but I just if you wanted to kind of handwrite that, sometimes it helps me to kind of go through stuff versus me just like, oh yeah, it makes sense on the screen. So me actually kind of writing stuff out is helpful for me. Okay, so we have a 9-month-old, weighs a little over 13 pounds, and they have an order for amoxicillin. Surprise, surprise, right? Lots of babies have ear infections. We need to have antibiotics. So the dose that was prescribed was 333 milligrams by mouth every 12 hours for 7 days. So based on this prescription, calculate the dose volume for each dose using the 250 milligram per 5 ml concentration. And then while you're at it, calculate how much volume will be needed to complete a 7-day course. Okay, so let's do a little math from the prescription. So again, this is our patient info in the prescription that was received. And then here's our math. So if we have 333 milligrams as our dose, then we know our concentration is 250 milligrams per 5 mils. Do solve for X, and you get about 6.7 mils. Okay. Now I want you to think, 9 months old, 6.7 mil dose. I could not have given my little kids 6.7. So there's your, is this correct? Not sure. You're not sure exactly what's wrong. It's right compared to the prescription, but something doesn't seem right, not for a 9-month-old. And then your volume for 7 days, 6.7 times 2 doses a day, so 14 doses, almost 100 mils. All right. So you go to the pharmacist or maybe the pharmacy student and like something doesn't quite seem right. Okay, well let's look in a drug reference. And in a drug reference, you see that that's really the dose is 25 milligrams per kilo daily in divided doses every 12 hours. And the reason I emphasize that in divided doses, because sometimes your eyes want to jump over that. Your eyes want to read amoxicillin 25 mg per kg every 12 hours. But if we do that, we've doubled the dose. So we have a scenario in the compounding lab where the students have to interpret not necessarily amoxicillin, I think it's vancomycin, but it's dosed that same. This is the daily dose in 2 to 3 divided doses. And when they get it wrong, they're like, but the math's right. And I'm like, read the dosing. Oh, so when they read it out loud, they get it. In divided doses. Okay. All right, so now based on the dosing information from AHFS, which is the American Hospital Formulary Service, calculate the dosing weight. So you need to know the conversion factor from pounds to kilos. The dose per day, so how many milligrams per day will this patient need? How many milligrams per dose? And then what's the dose volume? And again, how many mils do we need to dispense? Okay, so I just copied over the patient info in the dosing instructions just for completeness sake. All right, so for dosing weight, we start out, I think, with I can't read that very well, so 13.3 pounds, and then divided by 2.2 pounds per kilo, so we get about 6 kilos. How many milligrams per day? So 25 mg per kg times 6 is about 150 milligrams per day. But now I have to divide that by 2 to get my milligrams per dose. So then I have 75 milligrams per dose. We're still going to use that 250 milligram per 5 mil suspension. So when I solve for X using a 75 milligram dose, I get 1.5 mils. That feels much better for my 9-month-old than my 6.67 or 6.7 mils. And then my dose to dispense, or I guess the total volume for that particular patient would be 21 mils. And I know it doesn't come in a 21 mil bottle. We'd have to give more. But that would be the total volume that the baby would receive. All right, so for our calculations, so basically it's which one's correct, right? So we have each dose 6.7 mils for a total volume of 94 mils to be dispensed, or 1.5 mils for basically for 7-day course, 21 mils total volume. What sounds better to you? Yeah, the 1.5. So that would require a doctor call, a prescriber call, right? Because that's not what the prescriber ordered. We can't just change it. But we would have some background. Okay, this is the reference we used. This is the calculations that we made. This is what our recommendation is. And hopefully they would say yes. All right. So my caution for all of us is pediatric medications are often dosed in milligrams per kilo per day in some type of divided doses. And so just like, oh, pediatric patient, and you see, you're like, okay, what is the dose? So if it doesn't seem right, what's actually ordered, and the prescribers are encouraged to put how they're dosing that. So our pediatrician always put if they're ordered, if the pediatrician ordered Septinir, she would always put the milligram per kilo dose that she was basing that calculation off of. But I know not all do that. But just kind of have your radar up, a pediatric patient, antibiotic. Let's see if it matches what our reference says. Any questions or comments that you would like, something like you would like to share from your experiences on something similar? Okay. All right. So just, you'll probably hear this again, but read the dosing information aloud. We talked about that just a few minutes ago. And then ask for an independent dose check. So if you're calculating something and you're not sure, don't have somebody, hey, check my math, because they're probably going to make the same. If you made an error there, they're going to maybe make the same error. But just, hey, you'll calculate it separately, and let's see if we get the same answer. All right. So basically, kind of what went wrong here. So the prescriber calculated the daily dose in pounds. So they did the 25 times 13, got the 333. And then they didn't divide it by 2. So instead of the person receiving, anyways, the baby would have received 4 times what was the normal dose. Okay. Now, would the patient be harmed? Probably not. Might have had some really bad diarrhea. Would have gotten that pink liquid all over the place trying to get that 6.7 mils in. But if we can kind of capture that ahead of time to prevent that, be in better shape for everyone. All right, so that was the pediatric patient, our first scenario, basically a milligram per kilo per day, and then a dose conversion, a weight conversion calculation. Okay, next one's going to be, the setting is in a hospital pharmacy in the ICU. Patient is on a dopamine drip, and they're going through it pretty quickly, and so the nurse calls down and says, hey, I want you to double concentrate that dopamine drip. So just a little background in case you haven't practiced hospital pharmacy. Our standard concentration, and it comes in a pre-mixed bag, is dopamine 400 milligrams per 250 mils in D5. And so when we're building the order in the computer, let's say we selected a D5W 100 mil bag, and then dopamine vials that were 40 milligrams per mil in a 10 mil vial. All right, and so the task is to calculate the volume of dopamine that we need to double concentrate that dopamine drip. All right, so there's going to be 2 calculations here. Let's talk about which one is correct. And I'm going to actually start with the one on the right. So the one on, well, maybe not. I don't know. I'm changing from what I was going to do, so we'll keep it standard. Sometimes I jump ahead of myself. All right, so as you're looking at this particular equation set, so dimensional analysis, but there's no units. I'm missing my units. So I'm going to increase my risk of maybe flipping something because I'm not going to be able to, I don't have anything to cancel out here, right? So my 400 per 250, I can intuitively say, okay, that's 400 milligrams per 250 mils. I got that. The times 2 over 1, that's my double concentrate. All right, got that. 40 per 1, so it's 40 milligrams per mil. That's one of the errors there. It's on the wrong, it's flipped. The 40 should be on the bottom. And then if I do that calculation, it's like 12,000. Anyways, it's a lot of mils if I do this, and if I did like times 100 mils, because I don't know why you would divide by 100 there, but we divided by 100, and they got 1.28 mils of the 40 milligram per mil dopamine. Then here we have our units, right? So now we can kind of visually cross out. So we have 400 for 250, that's the same. The times 2 over 1, so we're double concentrating it, that's the same. But now, like, okay, so do I put the 40 milligrams on the top or on the bottom, well, now that I know that if I'm going to do my dimensional analysis, I want to be able to cancel out my milligrams. So my milligrams my 40 goes on the denominator, right? Goes on the bottom. So then I'm able to cancel out my milligrams. I'm able to cancel out my mils times the volume of my bag, and I get 8 mils. So the question is, which dose volume, the 1.28 or the 8 mils, which one is the double concentrate? Which one would be double concentrated? So this is kind of where I'm going to probably go to, because I think there's a step here that to provide some context that would be helpful. So because I'm familiar, because I teach in this room, we're going to use the dot cam. Okay, maybe. Where's I should have practiced this before. I don't know why it's not popping up. Okay, there it goes. All right, so we talked about how we had 400 milligrams divided by 250 mils. And I think somebody can do the math, but I think it's 1.6 milligrams per mil. So that would be the regular strength or the regular concentration. Actually, we'll call it standard concentration. Okay, so if I want to double strength it, so times 2, right? So 800 milligrams divided by 250 mils. That gives me 3.2 milligrams per mil. Okay, so now we have our, let's see here. Okay, so our choices were 1.28 mils of the dopamine. And then remember our concentration was 40 milligrams per mil. Or 8 mils of the dopamine. Same concentration. Okay. All right, so if I have, let me think a minute. So, all right, so I have 8 mils times 40 milligrams per mil. All right, and that gives me 320 milligrams. And what size bag did we have? We had a 100 ml bag, right? So that gives me 3.2 milligrams per mil. So let's do it with, same thing, well, let's do it with 1.28 mils of dopamine. So same thing, I've got 40 milligrams per mil. So that gives me 51.2 milligrams. If I divide that by 100 mils, I get 0.512 milligrams per mil. So our standard again was 1.6 milligrams per mil. So instead of double concentrating it, if I kind of flip my units like we saw on the screen, I'm actually less than half than what I was supposed to be. You follow? Yeah. Okay. So good to have a double check. If you're making something that's not very common, have somebody independently double check you. Okay. So I'm going to turn this off just for a sec. Okay. All right. So just for completeness, we're going to put 8 mils of dopamine in our 100 ml bag. We might pull out the overfill, but this is not a sterile compounding talk. For a concentration of 3.2 milligrams per mil. So make sure that when you're calculating some things that you include those units so you can check yourself if you've actually flipped something. You're like, oh, well, it's actually 40 milligrams per mil, so I need to put the milligrams on top so they cancel out. Okay. So what happened here? Well, the technician whoever, it could have been pharmacist, whoever was calculating it, the calculator, lost track of the units. And so just ended up giving a lower than the standard concentration for this particular patient. In the ICU setting, that could be serious, right? So depending on the rate of dopamine, dopamine is used to help increase heart rate, increase blood pressure. And if the error is not caught, then maybe the prescriber, physician, would maybe add another drug to help increase blood pressure and heart rate. And so now that one error has caused some other things to be done to the patient when actually we had a calculation error and our dopamine. Good? And then, you would have a pharmacist check you. If I'm at the pharmacist, I'm going to ask you to check me. Because again, technicians have saved my rear end with regards to calculations. So I'm going to share one with you. So I'm a green pharmacist. I think I've been practicing 3 or 4 months, and they had me work in the ICU. Like, that wasn't a very good staffing choice, in my opinion. I didn't really know what I was doing. So I had a patient that was in diabetic ketoacidosis, or DKA, and they needed an insulin drip. And so our standard concentration is 100 units of insulin and 100 mils of saline for a concentration of 1 unit per mil. And we have a hood in the ICU satellite, and I could have made it, but you know what? It's not like dire. I'm going to send it down. So I enter the order, send it down to the compounding lab, and it needs to be checked. And the other pharmacists are crazy busy. So I'll run in there and I'll gown up and check it. And I was like, wait, shouldn't it be the whole vial of insulin? Because, 1 vial in the bag, right? Oh, no. That would be 1,000 units of insulin in a 100 ml bag, so 10 units per ml instead of 1 unit per ml. So had the technician not made that, I would have made it incorrectly. So I tried to tell the tech, I'm like, that's not wrong. She's like, no, Holly, it's 100 units per ml is the concentration. Like, oh, yes, you're right. So I want you to advocate for your competency, for your calculations, because you guys see this stuff all the time, and the pharmacists sometimes rotate, right? Or you have somebody visiting for the day, and they don't know the flow. You guys do. Okay. All right. Okay, so third scenario, this isn't necessarily a harmful type scenario, but maybe from a cost perspective. And it kind of deals with the dosing regimens that change. And so that should be another a little radar go up. Okay, this is kind of an unusual order. The dosing frequency or the amounts change, and so that needs to have an extra eye. All right, so here we have a patient, sucralfate suspension, 1 gram every 6 hours for 14 days, and then we're changing the frequency. Same the dose, we're still going to go with 1 gram, but every 12 hours to prevent ulcers. Okay. How much fluid do we dispense? Well, we're going to QS it, so we're going to do our calculations and dispense whatever that volume is for the initial month, and then we will change for the 1 gram every 12 hours. So it has a lot of refills. So we're talking about 6 months worth of therapy. So how many mils do we dispense for that first fill? So that's our first calculation. And then how much volume do we dispense for the remaining refills? So I'll give you just a second. If you want to pick one, I want you to pick that first bullet. What is the volume to dispense for our first fill? Okay, so we have our prescription up there at the top. How many mils do we need for our first fill? So let's first think about that first chunk. So it's 10 mils per dose times 4 doses a day, because it's every 6 hours, for 14 days. So that gives us 560 mils. And then okay, how many days are left in that month, right? So 30 days minus the 14 days that we've already counted for. That leaves me 16 more days to figure out the dose, how many doses, or what is our dose volume for that. So then 10 mils times 2 doses a day for the remaining days. So for the 16 days, that gives us 320 mils for a total volume to dispense for that first fill of 880 mils. Good? All right. So the next one is, so we already figured, let's see, I had that twice for some reason. Okay, so now we're doing the refills. So for our remaining refills, we have 5 refills. So then we'll have, it's just 2 doses a day, so 10 mils times 2 doses a day times 30 days. That gives us 600 mils for each refill. All right, but what if you only read, or I only read, sucralfate 1 gram every 6 hours with 5 refills? So I didn't finish reading the rest of the prescription, right? So if we did 10 mils times 4 doses a day times 30 days, 1,200 mils for all the refills. That's a lot of fluid. Okay. So our previous calculations, we had 880 mils for that first fill, and then 600 mils for the remaining. Oops, 600 mils for the remaining. Let's see. I'm afraid my things got mixed up. Okay. All right, so correctly dispensed, if we may, 880 mils for that first fill, 600 mils per each refill. So if I multiply that times our 5 more months or 5 more fills, that gives me 3,000 mils for a total dispense, just a little less than 4,000 mils. But if we incorrectly dispensed it, we didn't finish reading the full prescription. We just did the 10 mils every 6 hours for the duration. That gives us over 7,000 mils. So we end up, long story short, we end up giving the patient over or about 8 extra bottles. And I have some math here for you. Now this, I got this from, I don't think I put it on this particular prescription, but it's when bad math, I can't even read my thing. Anyways, we'll get it in the next one. But I got it from PharmD, or when bad math goes wrong, I can't read the particular source. Yeah, help me out, Roxanne.
When bad math makes its mark,
there you go.
From PharmD or Matrix.
Yes. So when they did this calculation, the AWP of each bottle was like $208. Now it's about $1 a mil. So if it's 420 mils, it's about $400. How can Carafate be that expensive? I just don't understand. Anyways, so it was an overcharge of about $1,600. And so the patient had insurance, but then the insurance was, overcharged, and the insurance ended up doing an audit, and they had to, the insurance take that money back from the pharmacy, right? And so it was a hit from the pharmacy perspective because they had already dispensed the dose. They don't get that dose back, but they had to pay back the insurer. So that was a financial hit for that particular pharmacy. Okay, so what have our lessons learned in this particular scenario? It's like, so when you see dosing regimens that change over time, whether it's changing in frequency, like this one went from 4 times a day to twice a day, or perhaps, you had those steroid tapers, and you're always kind of calculating, okay, 20 milligrams for 4 days, 15 milligrams for 4 days. You're trying to calculate how many tablets I need. So have someone double check you, just make sure that we get our math right and that we're dispensing the appropriate quantity. Anyone have any examples from their practice that they would like to share? Okay. All right, so this was an example of how this particular error could impact some revenue, right? So instead of just needing this one bottle to dispense, we actually dispensed a lot more. Okay, so why do these things why did this happen? Well, first of all, we're human, right? And maybe we just have some simple math errors, like our first scenario, some unit conversions, second scenario too. Factors of 10 error, my insulin drip example that I provided, that would have been a factor of 10 error. Patient would have got super hypoglycemic had it been 10 units per mil of insulin instead of 1 unit per mil. And then kind of visualization problems. So when you get an answer, does that answer make sense? Is it reasonable? Is that a reasonable quantity? So for unit conversions, what are you starting with and what do you need to end with? And this is probably, it's basic for you guys, but I just want to emphasize it. Setting up the conversion factor as a fraction that equals 1, and then perform the calculations. Keep track of your units. So, how many seconds are there in a day? And so our goal is, starting with day 1, try to get it into number of seconds. And so here are our conversion factors. So I'll give you just a minute to calculate that. So we're practicing our dimensional analysis here. It's kind of hard because you're not doing drugs, right? Okay. I'm just going to do a little dot cam on this. All right. So we've got one day. There's 24 hours in a day. There's 60 minutes per hour and 60 seconds per minute. So let's see if my cancel out. So my days cancel out. I wasn't consistent here on my hours, so let's make it consistent. My hours cancel out. My minutes cancel out. And I have seconds left. And that was the goal, right? We started with a day, we ended with a second. And it's a big number. That's a lot of seconds each day. Okay. So every second, people say every second counts. That's a lot of seconds that should count. Okay. So this is just a good example of like the dimension analysis is trying to keep track of your units, right? Okay. All right. Did duplicate. Okay. Come on, baby. There we go. All right. So best practices, keep track of your units. And then this is a little test for you. So I want you to commit to an answer. I'm not going to ask you to raise your hands. But if you're writing something out or if you're typing something out and you have a dose that is less than 1, should it be 0.25 or 0.25? Thank you for adding that 0. Yes. So if you have a dose that is less than 1, you need a leading 0. What about 1.0 kilos versus 1 kilo? Okay, you guys know this. So if you have there's no trailing zeros on a whole number, right? Good. Okay, so you got that. Check. Now you'd be surprised. I'm telling my pharmacist, it's point this, it's point that. I'm like, I want to have the 0 point, please. 0 point, because if that dot's not very big, we'll make a big error, right? There's a lot of big difference between 25 milligrams of digoxin and 0.25 milligrams of digoxin. Okay. All right. So this is a simple equation. A simple calculation, but my goal is to kind of show you when things go awry and kind of the visualization piece. All right, but we'll start out simple. Sertraline, oral solution. The dose is 100 milligrams daily. It's available as 100 milligram per mil. The dose is 100 milligrams. The solution is 20 milligrams per mil. So similar questions, right? What is the daily dose in mils per day? 5. You do that in your head, right? So 5 mils per day. And then how many mils are needed for a 30-day supply? 150. Good? Okay, you got that. No problem. Okay, so there's the math in case you were like, how do we do that? All right, so now visualization. So our dose was 5 mils, right? And so we can use a dosing syringe or a dosing cup. That works. I can draw those back into a 5 ml dose. I'm good. And it's 150 dose, we said, so we probably use that 6-ounce bottle to dispense the liquid in. Okay, check, check, check. What if someone calculates the dose to be 2,000 mils daily? So what happened there? Yeah, so they have the milligrams on the bottom, the mils on the top, okay, but it's not 20 mils per milligram. If they're going to do it that way, it would be mils over 20 milligrams. Now, I like to put my milligrams on top so I don't get confused sometimes. But, you know, people do things different ways. But they got the mils and milligrams mixed up there. Okay. So, visualization, 2,000 mils. Okay, and then for 30 days, 60,000 mils to be dispensed. Really? Okay. Well, what does that really look like? So, visualization. Okay, so is it practical to have a 2-liter dose every day? Right? No. I see lots of heads shaking no. Maybe if you're getting a colonoscopy. I don't know. But that would be the only time I think we're drinking that much fluid. Okay, 30 2-liter bottles. That's not very practical. But I think sometimes, at least from this actually came from a pharmacy student calculation. We're trying to see where they are, and this was actually an answer that was provided. And you're like, think about it. You did the math, okay, but does the answer make sense? In this case, it does not. So we kind of took that and then ran with it. All right, so develop a process. And I know you guys are better than I am for sure with getting the flow. You know the flow. You follow it each time. But pick an equations that you like, that you are confident with. There's more than one way to get to the correct answer. And at least my pharmacy students, I want to know the exact way to do it. We can do it many different ways, and you might want to do it a couple different ways to see if you get the same answer both times. So kind of picking some type of method that you like. All right, so kind of what's our goal, right? So we need to figure out what's being asked, what's the relevant information that I need to solve the problem, if you may, what equation can I use, and does my answer make sense? Okay, so for our last case question. So we have a prescription for a 5-year-old, weighs 35 pounds. They've ordered Septinir twice a day because the poor little guy has an ear infection. So they're telling us that the dose is based on 7 mg per kg per dose every 12 hours. And we're planning to dispense the Septinir in 125 milligrams per 5 ml concentration. So how many mils are needed for each dose? And then how much do I dispense for a 10-day supply? All right, so the answers are kind of in green there. So what's being asked, how many mils do I need for each dose? And then how many mils do I need to dispense to complete the therapy? What information do I need to solve this problem? Lots of stuff, right? I need to know the weight of the child because it's dosed at 7 milligram per kilo. Patient weight is 35 pounds, so now I need to do a dose conversion. The strength of the product that we're going to dispense, 125 per 5. The dosing frequency, every 12 hours, so twice a day. And then how long? For 10 days. Okay. And then for our calculations, you can use division, multiplication, proportion to figure out the answer. I don't know why that keeps going. There we go. Okay, so my little animations didn't work right on this slide, so I apologize. So step 1, what is our patient weight in kilos? So you either use division or ratio proportion. So 35 pounds divided by 2.2 pounds per kilo. That gives us about 16 kilos. And it's really not dose strength, it's really dose volume. So based on the child's weight, or the dose, just determine the dose based on the child's weight and dosing recommendation. So 7 mg per kg per dose, and then that gives you the total milligrams per dose. Step 3 would be to determine the dosing volume based on the dose that I calculate. So if I'm using 125 milligram per 5 mil concentration, and my dose is 111 milligrams, I'm going to solve for X, which gives me 4.4 mils per dose. And then how many mils do I need to dispense for 10-day supply? So it gives me 4.4 mils per dose times 2 doses a day times 10 days gives me 88 mils to dispense. Well, let's go back and think. Does this volume, 4.4 mils, does it make sense for a 5-year-old? Yeah, I can probably get 4.4 mils. I might need to flavor it with some fun flavor, but yeah, I can get 4.4 mils down my kid. And can I measure it using standard dosing devices? Yeah, I think I can get 4.4 mils out of the, now maybe not the unit dose cup, but I can pull that in a syringe. So that makes sense. Okay. All right, so there's it in bright blue. There's our responses. Okay, so just to close up here, kind of our main takeaway is that it's not just getting an answer, it's getting the correct answer, right? So we need to make sure that as we're setting up our calculations, that we're thoughtful in our setup, that if we're using dimensional analysis, that we are actually using our units, and that we have some independent checks and double checks built in, and that we're visualizing our answer. Does that make sense? And listen to your gut. Listen, if something's good, not sure, this doesn't seem right. It's taken me several years to learn to listen to my gut, and I'm getting to have a good gut, but I wish I would have learned to listen to it earlier. Not just with, I think I was pretty good as a pharmacist listening, as a tech listening to my gut, but not so much in life. But I've learned it's good in life as well as in my pharmacy world. So, all right, so questions?
My question is regarding how do you go about nowadays the over-reliance on technology? I have newer technicians that have no idea what's going on as if let's say for instance system is down, we have to rely on paper labels. They have no idea what's going on. They can't do any of the math. And doing our SOP calls for them to go through a calculation problem every 6 months. It's a short calculation. It's not really. I feel like it's
checking the box.
It's checking the box pretty much.
Yeah.
How do you go about
I wish I had a good answer for this. So the question, I'm going to rephrase it, so correct me if I'm wrong, but the overreliance. Why do I need to learn how to calculate it? I can just put it in Google, or I could put it in ChatGPT, or the calculator's already there. I just plug in the stats. The patient weighs this amount of kilos and 7 mg per kg. Well, that's great, but what happens when it goes down, or what happens if something gets tweaked? We don't know if they're going to. We need to know if it's practical. So, we have a students on IPI rotations, which is introductory pharmacy practice experiences right now in the hospital setting. And so one of the tasks that one of our students has been asked to do is to, in the IV lab, is to kind of determine which drugs are calculations required, and asking them so she's building a quiz, like 10 questions, for her technicians and whoever else is compounders. It's not just the techs that need to know, it's the pharmacists too. So, on maybe it's for the every 6 month check. But I think you're going to have not just the math, do the math, but I think you need to have either the picture of the label with you, or have the actual product, so they can kind of see, okay, this is the product, this is the problem, so they can kind of connect the two. I have students that can do good if I just have some paper problems, but once I put it this is the actual prescription, even if it's very similar, they can't do it. It's baffling sometimes. And my dad would kind of complain to me because I can't do math in my head very well. And he had to use a slide rule, right? So he can do math in his head great. And so I feel like it's that same, I've lost that math in my head skill, but I know how to write stuff out and calculate it. And now the younger generations, they just plug something in and get the answer.
I forgot to mention that even our pharmacists, a few years back, I can remember us going through a cyber attack in the hospital, and just the
Ascension?
TPNs to write those
Oh, yeah.
TPNs on papers, it was a daily struggle. So
Yes, and I think I'm crazy when I'm like, you have to learn how to do this stuff on paper. Anyways, I got a little more credibility when the Ascension was down for 4 to 6 weeks or so. Like, oh, how do we do this on paper? But if you hadn't done it on paper, so the people who had actually not had EHRs forever, they could do it, but it was a big learning curve, right? I do think maybe having some kind of group, this is kind of the good group to ask. So I want to ask, that was kind of my response. Anyone experienced a similar situation and have discovered something that works for your facility with regards to kind of keeping people on their toes with regards to calculations? Anyways, thank you guys for your attention. It was a pleasure to be here with you today. I will bring your question forward. So next week when I'm there, I think that's a good, how do we solve this, right? It's a good problem to solve. All right, thank you. And thank you for this. This is lovely.
Yeah, well, I wanted to, I'll just read. I think
Yeah.
they all say the same, but with gratitude and for sharing expertise
Awesome.
and inspiring pharmacy
Yeah,
technicians.
so thank you guys.
yeah.
This is lovely.
Thank you.
Appreciate it.